Module 14, IDR in Posterior Regions. Here in this module, I will share with you the IDR application in posterior zone. It's very important to pay attention now, especially on the cares related to the occlusion adjustments. I'm going to carry on using corticocancellous graft in posterior region, the same way that it was performed in anterior regions, upper and down. In this particular clinical case, this is another patient that has parafunction. This patient fractured the second molar in the left side, a longitudinal fracture. But through this X-ray, you can see the amount of bone that we have all around this damaged tooth. But not only that, we have a huge amount of available bone behind this tooth. So it's very easy to deal with. It was confirmed the fracture through this CBCT scan. So the tooth was extracted, applying minimally invasive procedures. Here we have the presence of the infection and fistula at the palatal aspect. We have to be careful during the extraction to avoid tearing soft tissue at the palatal aspect. And how about the implant position? We have to insert the implant at the interdental septum. The implant was placed, the provisional crown was made, a screw retained provisional restoration, and take a look where the hole of the screw retained provisional restoration was placed. Exactly in the middle of the crown, in the buccal palatal direction and the mesial-distal aspect. It was performed a crestal incision. The flap was raised in both sides in the buccal and the palatal direction. The bone was harvested using a curved chisel from the buccal aspect and the palatal aspect. And all bone that was harvested was inserted in a container. And after that, we start the bone reconstruction. First of all, we inserted a corticocancellous graft to restore the palatal wall. And after that, the particulate bone was packed to fill completely the gaps. All the space around the body and especially the head of the implant. After this procedure was finished, the cover screw was removed and the provisional restoration was inserted. And here the main care is the height of this crown. We have to leave this crown shorter than the last tooth to protect this tooth from the antagonist arch during chewing or when the patient is biting over this area. Behind the last tooth, it was performed the suture using simple stitches. This is a kind of case that we consider and we expect very low morbidity, no swelling, no pain, nothing. But one of the criteria that we have to pay attention here is the implant stability. The implant stability should be equal or more than 30 Newton centimeter. Of course, the higher primary stability would be preferable, especially in posterior zone. That's why we have to do the site preparation using all your skills and technology available in the market. When we insert the implant in the posterior zone, we should make an agreement with the patient. In this agreement, we should split the responsibility with the patient. 50% of the responsibility belongs to the patient and 50% belongs to us. And we have to explain to the patient how to follow this protocol. Because if the patient don't obey the order, start chewing or biting over the implant, we will fail. This is our job, to make this agreement with the patient before we do the surgery, especially when we intend to insert the implant in posterior zone. Second, no occlusion contact over this provisional restoration for at least 3 months. And the cares, not only about the occlusion, but how to clean this area. And for 3 months, If you have the opportunity to see this patient very often, this is my first recommendation. And we have to see this patient frequently, especially in the first and the second week after the procedure is finished. So in this case, it was done here, the buccal bone filling and the palatal bone reconstruction. This x-ray was taken before the procedure, the second one before graft removal, and this third one right after the graft was removed. And you can see here that the bone was taken from the posterior zone of the tuberosity. How about the CBCT scan? This is the immediate post-op. You can see the presence of bone all around the head of the implant and the body of the implant as well. And pay attention to the thickness, not only the buccal wall, but the palatal wall as well. And through this axial view, you can see that the bone was packed in 3D position all around the implant. 1 week post-op, I want to call your attention to the healing of soft tissue where the abscess started. 2 weeks post-op, we cannot see the presence of the abscess anymore. And we have a very good healing of soft tissue all around this provisional restoration. 3 months after we applied this technique in the second molar, it was taken impression and it was fabricated the final screw retained ceramic restoration. But we can pay attention in the ideal emergence profile not only during the provisional crown fabrication, but we have to reproduce exactly the shape of the anatomical contour of soft tissue to perform the final restoration. This is the correct emergence profile of this final restoration. We can leave a slightly concave contour in both sides, in the buccal and the palatal aspect. And take a look at the 3D implant position, exactly in the middle of the crown. This is our target when we insert an implant in the posterior zone. 5 years post-op, here we have a panoramic radiograph and the X-ray and the CBCT scan. Take a look at the bone remodel at the tuberosity area. And sometimes we can take bone 2 or 3 times from the same donor area if we need it. Here the thickness of the palatal wall and the thickness of the buccal wall. Another clinical case, we have the same problem, but in this case, in the right side. The first molar is condemned to be extracted due to the same reason, the fracture. And we have the presence of the abscess and fistula at the palatal aspect. Through periodontal probe, you can see the way of the fistula. The tooth was extracted, the interdental septum was maintained, and the implant was placed exactly in the middle of the interdental septum. We got a very good implant primary stability, over 40 Newton centimeter. And we have 3 defects to be restored in this case. It was missing the buccal wall and the palatal wall as well. A defect type R3 and 6 to be restored. The bone was taken from the same side of the problem, the right tuberosity, and just moved bone from the tuberosity to the receptor side. And first of all, we restore the palatal wall using a corticocancellous graft. And take a look at this image right after bone reconstruction at the palatal aspect. And we did the same in the buccal aspect. We insert a corticocancellous graft plus particulate bone, and now you can see the presence of bone all around the head of the implant. So in this case, it was performed the buccal bone reconstruction and the palatal bone reconstruction, and bone filling all around the implant. This is the immediate post-op after provisional restoration in place, a screw retained provisional restoration. This is our preference, regardless of the tooth to be replaced. Upper, down, anterior or posterior, doesn't matter. Screw retained restoration is one of the keys to succeed with the IDR technique. 2 weeks post-op, we cannot see the presence of the fistula anymore. it vanished from here, but we have a very good healing of soft tissue around this provisional crown. And 3 months post-op, take a look at this anatomical contour of the provisional restoration. Now it's time to reproduce the same anatomical contour in the final restoration. The volume of soft tissue is being maintained in the same position, and we manufacture the final restoration. A screw retained porcelain crown with ideal emergence profile. Here, during the final restoration insertion, and right after we deliver the final crown, and we close and we restore the occlusal hole with composite resin. And you can see the maintenance of the anatomical contour of soft tissue. The CBCT scan after 5 years. Take a look at the thickness of the buccal wall and the thickness of the palatal wall. Another case to replace the second premolar, a bicuspidal tooth. We have the same problem here, the fracture. We have an abscess, we have fistula, we have a very poor quality of soft tissue, especially at the buccal aspect. The tooth was extracted, we removed the granulation tissue, and the implant was placed in the right position, exactly in the middle of the crown. The bone was taken from the same side, the left tuberosity, using chisels, and we start the reconstruction. We use a double layer graft, corticocancellous graft, to restore the buccal wall, and particulate bone to promote bone filling. So we have the buccal bone reconstruction and the palatal bone filling in this case. It was inserted immediately, the provisional restoration, a screw retained one, and after 3 months we removed this provisional restoration, the impression was taken, the final abutment. In this case we use titanium abutment plus a cemented restoration, a cemented ceramic crown. This is the X-ray that was taken after final crown in place. This is before and 6 years post-op. Take a look at the improvement in quality of soft tissue before and after 6 years. We have the maintenance of the anatomical contour and a relevant thickness of soft tissue around this final restoration. We have the improvement in gingival quality and volume of soft tissue. 10 years post-op, let's carry on following this clinical case. After 10 years, in the second premolar, it was inserted in implant and it was applied an IDR technique. But in first premolar, a couple of years before we performed the IDR in the second premolar, it was inserted an implant in a healed site. And take a look at the difference in thickness of the buccal wall inserted in implants in a healed site and a post-extraction socket. This is what I usually say, that a post-extraction socket would never become an edentulous site for late implantation. It's because it would increase the number of the procedure, the cost and the treatment time, and of course the unpredictability of results. The application of the IDR technique in posterior regions is feasible as long as some precautions are respected, especially regarding the implant primary stability and the construction of the provisional crown.